Good evening, everybody. We are here with Dr. Rankin from the United States, one of the main cardiac surgeons in the world, especially in the field of aortic valve repair. So we are here to ask him a few questions. First of all, what do you think are the key factors to determine whether a patient is suitable for aortic valve repair?
Well, the main thing is the pathology on the valve. So if there's aortic insufficiency, it is more likely that the valve can be repaired, depending on the pathology. Certainly in bicuspid disease with aortic insufficiency, almost all of those can be repaired now. If it's aneurysmal disease and AI, the majority can. And you know, if we get into calcified valves and aortic stenosis, it becomes more difficult, although there are small segments of that group that we are repairing now. And it's helped a lot. We've been using for the last 2 years leaflet substitute patches of aortic wall, autologous aortic wall. So that allows us to replace leaflets that are calcified and be able to do repairs even in those kinds of cases. But our goal is to repair more and more aortic valves in general, insufficient or stenotic. The benefit of which is fewer long-term valve-related complications and a better survival. We're going down the path that we went through with mitral valve repair, where in 1980, we really were just starting. We didn't have the techniques developed. It really took us another 15 or 20 years to develop artificial chordal replacement and other aspects of mitral valve repair so that we could assuredly operate on a patient and have them live the rest of their life without recurrent valve disease. And so that's all been developed, and it's unbelievably successful. We just had an STS paper published on that with an operative mortality for repair in the United States of 0.6%. So that's what we're attempting to do, is to follow the same pathway in the aortic valve so that we can repair more and more. But certainly the insufficient valves are the first ones.
So probably we will see the results in the next 10 years, let's say?
Yes, and you know, we are analyzing our results continually, and they look very good right now. The whole thing with repair is to use autologous tissues, and so they don't fail, they don't clot, they don't have, you know, other valve-related complications if it's the patient's own tissue. But the Achilles heel is repair failure. So if you can get the repair failure very, very low, then you're in a position where long-term the outcomes can be markedly improved. And we've been working on this, on the internal ring, for about 10 or 12 years in patients, and we've had a progressive improvement in our early repair failure rate. So it's down less than 2% now within 2 years, and I think it's going to continue to get better. And so once we get to that level, then we can manifest the better long-term outcomes and actually do more patients. We have, every day we're developing techniques where we can repair this or that pathology that we didn't have before, and that has really allowed us to expand the repair.
Okay. And which advice would you give to a young cardiac surgeon who start to approach to the field of the aortic valve and aortic valve repair?
Well, I think it's very difficult to have a crystal ball and to know what's going to happen in the future. In my career, both with multiple mammary artery bypass and with mitral repair, tricuspid valve repair, I've chosen the general biologic principle that it's better to use the patient's own tissues to perform an operation. And that's what we're doing now in aortic valve repair, is we're trying to develop the techniques where we can use the autologous tissues of the patient to get a good valve long term. And that would still be the best approach in my mind. Now, it remains to be seen if that 10 years from now is the dominant approach. We'll see. It certainly has been for the other areas in the last 20, 30 years, but right now I think it's a good bet that autologous repair is going to really make a big difference in aortic valve surgery. The one thing that, you know, we've been studying a lot, the percutaneous valves, and they really don't do very well. And in my mind, that's a bad way to go. Okay. In this whole concept of valve and valve and valve, you know, the patient's sick for the rest of his life and then has a premature death for one reason or the other. And the whole concept of doing one operation with the patient's own tissue, repairing the valve, and then they have a life expectancy that's back to the normal population without further trouble with the valve, I think is the goal we should have.
Absolutely.
And but you know, we'll see what happens. There's a possibility that there will be the tissues will be developed that will last, artificial tissues, but so far that's not happened.
Okay, so far we are using autologous tissues. We try to use autologous tissues.
Well, no, the autologous tissues will last, we know, but if we use things like pericardium, bovine pericardium, and other tissues, the biopolymer valves now, you know, they have failure rates. They have very significant failure rates. So it's it may be, though, in the future that there is some tissue that's developed that won't have a failure rate that will be as good as autologous tissue, in which case that will then make it easy to take the field. But so far that's not happened. So I think still the concept of developing a repair operation that will use the patient's own autologous tissue to make the valve function better long term is the way to go.
Okay, thank you very much.
Thank you.